This conference will now be recorded.
Honorable guests and my fellow colleagues, Assalamu alaikum. My name is Dr. Muhammad Aziz, and I will be the moderator for today's OSP Clinical Meeting. On behalf of the administration of Mughal Eye Hospital Trust, I welcome you all to the second OSP Clinical Meeting. Before starting, I would like to request Dr. Zaid please to recite a few verses from the Bible.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم ياسين والقرآن الحكيم إنك لمن المرسلين على صراط مستقيم تنزيل العزيز الرحيم لتنذر قوما أنذر آباؤهم فهم غافلون ترجمہ یاسین والقرآن الحکیم قسم ہے قرآن حکیم کی انک لمن المرسلین بے شک آپ رسولوں میں سے ہیں علی صراط مستقیم سیدھے راستے پر تنزیل العزیز الرحیم یہ قرآن حکیم نازل کرتا ہے غالب اور مہربان کی جانب سے تاکہ آپ خبردار کریں ان لوگوں کو جن کے آپ کو خبردار نہیں کیا گیا ہم غافلون تو وہ غفلت میں پڑے ہوئے ہیں صدق اللہ العظیم
I will now request the General Secretary, Professor Hussain Ahmad Khan, to formally inaugurate the General Meeting.
Good morning, ladies and gentlemen. I welcome you on the behalf of the Mughal Society of Pakistan, Lahore, branch of the Clinical Meeting at the Mughal Hospital Lahore. I will just give a brief introduction of the Mughal Society of Pakistan, what we have done in the last 1 year. So we took the charge of society in 2022, and this is just for the information for the residents and new doctors and what opportunities that we have created for them and what they can enjoy the benefit from the OSP. First, we made the Ophthalmological Society of Pakistan Ethical Committee. If any resident is doing research and he needs ethical approval, that will be tricky for the private sector. So he can get ethical committee approval or ethical committee pursuance from the Ophthalmological Society where ethical committee that give that research approval. So that's the first target that we achieved in 2022. Next, our residents had a big difficulty in writing the articles, planning the research. So they need a biostatistician, and finding a biostatistician in Lahore or anywhere is a bit difficult, and they were feeling it cumbersome to find it. So we, after one society of partners, hired a permanent biostatistician, and he is 7 days in a week available in OSP office. Any resident who is planning the search, who is compiling the search, and who is writing the articles and who is preparing for his presentation, he can pursue the OSP office for any assistance regarding the biostatistician, any analysis, data conversion, study design, whatever you want, even he would help you for article writing. We also hired the OSP IT expertise here, so we started managing our website, and our website, this meeting is online, this meeting is also recorded, and this recording will be available on our website. So we have made this thing. First, this is online. Second, that it is being recorded. And third, it is available on the website. So if somebody cannot personally attend, he or she can attend from home. If he or she cannot attend from home or any workplace, they can even watch it later after tomorrow on the website. So the basic principle and basic theme is that knowledge has no boundaries. So we work on it. So, and second thing is that we have restructured the clinical meeting. We put the international speaker talk, and today you will see the body talk of international speaker. We put the guest speaker from local host talk on any topic. So these were few new things. And most important for the presenter is that who is going to win today is not looking for today only. So he or she is going to participate in grand clinical meeting. Grand clinical meeting will be held on the annual OSP meeting where all the years, those who are winning in the clinical meeting, from the Mughal Eye Hospital, those who are the winner in the presentation, they will compete in the grand clinical meeting at the OSP Lahore conference, and the winner will be named as a grand winner. We did it this year, first time in 2022 at ARCO, and this is much more encouragement for the resident. I will not take much time to a few more things that maybe resident know. We have included the full research grant. If you need any research grant for any of your research, we can give you up to 4 lakh rupees research grant to any resident. Just send us our synopsis or our proposal, we will give you 4 lakh rupees. Second, if any resident paper is accepted in international conference, we are going to give all the money that he or she needs from his or her home to back. It's air travel, accommodation, food, registration, everything. So this is a few things that we have brought in last 1 year. So this is much more encouragement for the resident. So now you have opportunity. Money is not a barrier now, and you should present at international stage because presenting at local meeting is something else. Presenting Pakistan at international stage is something more higher. So I think Institute Shabazz, they should encourage president they should present the papers in the international meeting. So we are ready to support you financially, full support from house to house. So there will be not a single penny expense of yourself. There are a lot more things, and one more thing. Here this hospital is lacking that nobody is not sending recorded video and photograph. We have started a postgraduate residence video and photography competition every 3 months. Those who will send, we will check the photograph or video, and those the winner will be announced at the end of the year, and they will get the souvenir or cash prize and the medals also. So we are trying to contribute in that. This is for the residents. There are a lot more I have to say, but I think we should continue for the clinical part of this meeting. So I will ask those to start the clinical part, and hope you will enjoy the presentation. And please start marking the. Thank you.
Thank you, sir. I will now request our administrator, Colonel Mia Mohammed Asad, to give a brief introduction about this hospital.
On behalf of our board of directors, doctors, and staff, I welcome you all. And not waste very much of time. Very important to be now, you already know about the Mughal Eye Hospital. We have an introduction that we have come before the corona and after the corona, the progress has been. I must tell you what all we have done. These are the departments from where we are getting the support, and the Honorable the Governor of Punjab has given us the due permission for the audience transplant, and as well as they have given the registration of the and the training of the FCK's part 2 with the see after my presentation, you see the PGs giving the presentation. So we have been able to make up how much effort our supervisors made. First of the Mughal Eye Hospital, we have constructed this hospital at about 2002, which consists of 5.5. And since then, we have been progressing, and you must be knowing that. These are our board of directors. We have 3 brothers who are in this NGO, and all the funds support is given by them. I just introduced myself. I have served for 28 years in Pakistan Army, and I got the honor to serve in the Gulf War also. We were told to go to Saudi Arabia and defend the Saudi Arabia land at the Iraq border. We were posted at Hello. Secondly, the main achievement is we have been involved in the special operation at Sindh. At the time before coming to the Rangers to come after us, at that time I've been doing an anti-car snatching, anti-kidnapping, and anti-body operation. I've been planning 1 year for Park Hospital, and I have the honor to make the Doctor Hospital function in 6 months. I did it Park Hospital, and then I joined Mughal Eye Hospital, and now next month I will be completing 21 years of service in the Mughal Eye Hospital. MS Dr. Shivasa is looking after the all medical fraternity. They are supervisor. Here I must tell you, because I've been getting a lot of calls from different partners. What I did is, after making these supervisors, I asked them to make a examination, written examination of the all PGs who want to inject it. And I made a medical board for 5 doctors, all were working independently. Whatever the PG you are seeing today, they all have come on merit. After that, we had an interview, and then we made a list of the merit, and like this, we got selected. This is a major achievement we have got. She is a Dr. Fiza Adam. She is a double FCPS. She just completed the pediatric and spin for FCP. Now we are having doctors, two doctors who are having 2 FCP. This is my future. Let us just give you a bit overview. Here I must tell you that one of the equipment we have is common Japanese, American, and German. We are not having one Chinese and Indian. This is this data scheme we are studying, which are depending on the 5 doctors. They are day by day, they keep changing and they keep having their own study. This is a cornea, which I just told you, we got a job sanction, and we have about 5 doctors who are doing this cornea transplant. We are being quoted by the American and I think we have next week we will be getting 5 cornea from the 7. This is orthoplastic department, and you are already aware of Dr. Khalid Saab. He is already looked after this along with 6 doctors. The board of directors asked me to develop on the hepatitis. So you can see there is a lot of time the hepatitis people are coming. We are having another daily number of 200 patients on hepatitis, and we are treated them free of cost. This is the data. When we started from 2017, until 6 years, we were able to do this 65,000 on this medical and the gas. Medical, what I said to the board of directors, we must have medical doctors, we have medical too. Because as I have observed, all the cardiac and all the local patients are suffering from blood pressure and sugar. I give them task within that because they should be fit enough to be very surgery. This is our annual patient starting from 2002. We have had total to see 2,89,000 out of 27 lakhs we have presented. And out of major surgery, we have done about 1,37,000. And the DETRA is looking after around 3,000. And likewise, orthoplastic with Dr. Shweta is getting about 7,600. And the test we have done on the request of doctors, we have done 11,000. That is one test, two tests, we will have done about, you can see, 50,000. And this is very strange for you people suffering. These are the institutions from where the students keep coming later and then they keep asking whether we have to go for the local genetics and microbiology have already आगे सर्च करते हैं या दूसरी और उसको करते हैं इससे और हम कॉलेज का भी कोई स्टूडेंट आता है उसको क्या करते हैं और मैं दूसरा ये कि I don't know all these principal of these colleges have come to know about us. They keep selling this 5 or 4 times. 65 institution which are sending us the new student and fresh student and about to become the graduate from the school and colleges. They send it for the internship. I take it like this. These are the those colleges with the elite class study. And elite class, if you have experience, they get out of the car from the house, they don't get to the college, and come college to class. They don't know what are the social evils suddenly so many people, social problems coming up. And sometimes I ask these children, they just tell me, who what is all this? They are very surprised to know. They told me that whenever the lady comes, so I was as a patient, I ask them who has brought it. They are always, they say they have three, four sons, but always daughters take the mothers or the mother-in-law, not the sons. Thank you very much. Thank you for the attention.
Thank you, sir. So we have five very interesting clinical presentations that have been diligently made by our postgraduate residents. For the first presentation, I would call Dr. Ali Hashim Zubair to present over here.
Assalamualaikum. I'm Dr. Ali Hashim, first year postgraduate resident, Mughal Eye Hospital, and today I'll be presenting a case about ocular deviation in a 9-year-old boy. Our patient, as mentioned, is a 9-year-old boy who is a resident of Lahore. He is currently studying in grade 3, and according to the parents' marriage, there was consanguinity present in their marriage. He presented to us with a complaint of inward deviation of the right eye, and according to the attendants, it was noted by them at the child's age of about 9 months. This was accompanied by decreased vision, which was first noted at around 2 years of age. Coming to the history of present illness, as mentioned earlier, the deviation was noted at 9 months of age. There has been no further deterioration in deviation. First consultation with the doctor was done at about 2 years of age, and since then, the child has been wearing glasses of various colors. No history of diplopia has been given, and the parents say that there has been no variation of any kind noted between the near and far fixations. Unfortunately, there has been poor compliance to the treatment, and the follow-up visits were also not made very much regularly. Apart from the deviation noted, there has been no significant vascular history in the patient. The child suffered from measles infection in his early childhood, and 4 to 5 years back he had typhoid fever. No other family members, either immediate family members or far family members, have had any kind of significant ocular disease or stroke. The child was born via spontaneous vaginal delivery, and at full term there is no prematurity. There has been no history of prolonged oxygenation therapy. There was no history of fits. Developmental milestones, including motor, intellectual, and sensory, were achieved timely. The vaccination profile was complete according to the then latest UTI schedule. So our first step was to perform refraction of the patient. First, we noted the number of the glasses which he was already wearing, and you can see there was cylindrical number which he was wearing. Unfortunately, with the old glasses, his vision in the right eye was very poor, that is 6 by 36, while in the left eye it was 6 by 6. So we then performed automated reflection, which came out as variable in its result. Then we proceeded to retinoscopy. The child was sent back home and was advised to come back after 3 days with atropine drops 1% in concentration to be taken weekly per day. So on retinoscopy, our result was a +5 spherical refractive error in both eyes. Our next step was to perform examination. On Hirschberg test, we noted deviation inwards of the right eye of about 15 to 20 degrees, as you can see in this picture. The next step was to perform cover uncover test, in which we read the right mesopropia. Then we performed prism cover test and noted deviation at both near fixation and far fixation with and without glasses. And as you can see, the difference between the two kinds of deviation is very slight. That is only 5 prism diopters or 2 to 3 degrees. The extraocular movements were noted and they were full. There was no over elevation or over depression in either abduction or reduction. Apart from these, all we performed routine slit lamp examination and the anterior segment was within normal limits. The last step was to perform dilated fundus examination and it came out as normal. This is a picture of the patient with the appropriate lenses in the trial frame after retinoscopy and the reflex has already become central as you can see. As mentioned earlier, we performed dilated fundus examination and took fundus photographs. They were both normal. So we can conclude that in his right eye which was deviated, he had amblyopia. We proceeded to calculate the accommodative convergence to accommodation ratio or in short AC by A ratio with the heterophoria method and by putting the values it came out as 3.55 and we know that the normal values range from 3 to 5. So in differential diagnosis, number one we have refractive accommodative esotropia, non-refractive accommodative esotropia and partially accommodative esotropia. Refractive accommodative esotropia is our probable diagnosis, and we have a few points to support it. Number one is that in refractive accommodative esotropia, usually we find that the patient has hyperopic refractive error of around 4 to 5 diopters, which was present in our case. Secondly, the AC over A ratio is normal in refractive accommodative esotropia. So in this way, we have ruled out non-refractive accommodative esotropia. Thirdly, the reflexes had become completely central after putting the correct glasses. So there was no residual deviation left, and this also rules out partially accommodative esotropia. So our plan was to send the child with full cycloplegic correction glasses, and as an amblyopia therapy, we had advised patching of the left eye 6 hours per 24 hours after school timing. We had counseled the patients. Actually, the father of the child was insisting on surgical correction of the deviation, but we had to counsel them about the importance of glasses, and that surgery was not required at the moment. And we had told them that we will slowly and steadily taper off the prescription so that better compliance will be ensured. And he was advised to follow up, to come on a follow-up visit after 1 month. So the patient came back after 1 month with the correct glasses in place, and you can see the deviation is gone, and the vision had improved from 6 by 36 to 6 by 24 in the right eye. We have basically two take-home messages from our presentation. First of all, we shouldn't rely solely on automated refractors, especially in the cases of children. The gold standard refractive error calculation method in children is still retinoscopy. Secondly, sometimes doing less is doing more. This is important for general public also that you do not always hastily proceed to surgeries for any deviation or abnormality you see. Sometimes you also have better and more convenient alternatives available, which has good results. Thank you.
So, are there any questions for this? No questions.
For retinoscopy, how long you did the cycloplegia?
So we while the routine blocks in PT and for the 3 days, the patient was
Before retinoscopy. How old is the child?
9 years.
9 years. Wouldn't you like to have a cycloplegia with cyclopentolate?
Sir, usually we do cycloplegia with cyclopentolate, but we wanted to ensure complete cycloplegia. It was better that would be, so that there is no residual deviation or spell.
Thank you, Dr. Ali. For the second presentation, I will invite Dr. Anand Khan to present.
Assalamualaikum. My name is Dr. Anand Khan, working here teacher at Mughal Eye Hospital Lahore. The topic of my presentation today is MBA deep overreaction and DBD. The patient 22 years old male presented with a complaint of right hypertropia in the primary position. The onset was since childhood. Past medical and surgical history of this patient was unremarkable. Past organic history in glasses, nerve surgery, or lasers was also unremarkable. Allergy history unremarkable, and socioeconomic status of the patient was of middle class. On examination, patient had a visual acuity of 6.6 bilaterally. Extraordinary movements were without any hypertropia. On virtual test, patient had a 15 degrees hypertropia in right eye, 25 degrees hypertropia under cover, and increased deep ovulation of +3 in right eye. On cover uncover test, patient had right hypertropia, and in present cover test, he had 30% arterial hypertropia in right eye. This is a clear picture of the patient and it shows right hypertropia. As you can see here, when fusion between the two eyes is broken, the right eye drifted upwards, showing DB, and on left gaze, the right eye again drifted upwards, showing inferior deep ovulation. Differential diagnosis of this patient was inferior deep ovulation, dissociated vertical deviation, contralateral inferior rectus paresis, and accidental severe oblique paresis. Surgery was performed on this patient. This video here shows antenatal transposition. Conjunctival incision was given 10 millimeters behind the limbus in intertemporal quadrant. Conjunctiva antennae lifted and inferior peak is put under direct visualization. Muscle is separated from the tenon and fibers are transmitted on the muscle sphere to isolate one end of the muscle till its insertion into the apparatus. 5-0 active sutures are passed on anterior and posterior border of the muscle. The muscle is clamped over artery clamp and cut. Bipolar water was applied on the cut end to cure hemostasis. Inferior rectus muscle is hooked and tenon cleared on its basal wall to expose the sclera. Both the needles of 5-0 double for double needle application to buffer the sclera and muscle attached on nasal side of the erectus. Inferior oblique muscle is pulled below the inferior rectus muscle and attached on its nasal border. Interrupted tenon sutures were applied and conjunctiva artery closed. Antenatal transposition. In antenatal transposition, performing sutures to prevent detachment and posterior fibers cross-threaded with non-traction. This picture here shows antenatal transposition and the 5-0 and the point sutures, permanent sutures that are used in this procedure. This is the comparison of pre-op and post-op pictures of the patient, and as you can see here, both eyes are aligned after the surgery and there is no hypertropia. On breaking the fusion, again, both eyes are aligned without any hypertropia in the right eye. And on left gaze, again, there is a line movement in between both eyes. In view of deep breathing, there are various techniques that are used to ensure deep breathing. This picture here shows normal insertion into deep muscle. The session of injury is one of the procedures that is used to ensure deep breathing. In this procedure, there is a removal and reattachment of the muscles so that its insertion is closer to its origin. As you can see here, injury is more closer to its origin, and this is a standard breathing procedure. Inward transposition is a procedure in which transposition of inferior peak muscle insertion to a position next to the insertion of inferior rectus muscle is performed. Normally, inferior peak is 4 millimeters component to inferior rectus muscle, and in anterior transposition, it is transposed closer to the inferior rectus muscle, both nasally and anteriorly. Myectomy is another procedure that is used for weakening, and in this procedure, a segment of muscle is resected away. Neonasal transposition, the procedure which we perform on our patient. In this procedure, insertion into the is moved anteriorly to a point adjacent to lateral border of inferior rectus muscle, and it weakens normal action of inferior oblique muscle. It is a relatively new procedure and it produces inferior oblique overaction. It is effective when both DVT and inferior oblique correction coexist. Inferior oblique muscle is transformed in this procedure from an exporter into an importer and from an alleviated to adipose to its action fluids. And this procedure is performed to severe excited torsion. Inferior oblique overaction DVT, what is inferior oblique overaction DVT? Inferior operation is one cause of unambiguation adaptation. Neither alleviated on adaptation in inferior overaction, and in DVT is upward with exposure of the eye under cover or spontaneously due to its visual inhibition.
After the examination, we wrote 4 differential diagnoses just after the examination. And then you directly moved on to the surgical procedure. Didn't you do the 3-step test or the Leach-Shamsky test? Find out which of the 4 muscles was at fault.
There was one extraocular movement of the patient and the extraocular movements all with dominated lobia. But there was
you didn't perform the 3-step test.
So, whenever I goes up in hypertension, we do the 3-step test. And the differential diagnosis includes inferior overreaction, hypertrophy, DVT, upshoot in brain syndrome, and sleep deviation. So these are the main differential diagnoses. So in this case, there was inferior overreaction or correction, and there was uplifting of the eye on cover. So that diagnosis was inferior overreaction plus DVT.
Thank you, sir. For the third presentation, I will invite Dr. Mariam Nasrullah.
Assalamualaikum. My name is Dr. Mariam Nasrullah. I'm second year postgraduate resident in Mughal Eye Hospital. The topic of my presentation is beware of the treatment. A 30-year-old male, shopkeeper by profession, unmarried resident of Lahore, presented in Mughal Eye Hospital on 2nd September 2022 with complaints of pain, redness, and blurring of vision in both eyes for 10 months. The symptoms were more at night time, and patient had history of instilled topical medications for several months, but there was no improvement in symptoms. Past medical and surgical history was insignificant, systemic history and rest of the history was also unremarkable. On examination, the best corrected visual acuity in both eyes was 6.9. The lids and adnexa were within normal limits. Krukenberg's spindle were noted in the left eye along with some lenticular opacities. The cup disc ratio was 0.8 and 0.9 in right and left eye respectively. This is a picture of the left eye showing Krukenberg's spindle in the corneal endothelium. Intraocular pressure on presentation was 50 millimeter of mercury in right and 54 millimeter of mercury in the left eye. We performed gonioscopy and it was noted hyperpigmentation in hyperpigmented trabecular meshwork with open angles. There was no peripheral anterior sign leaks or any inflammatory exudates, but a characteristic sympathy line was noted. This is a picture of the gonioscopy in which the arrow head indicates hyperpigmented trabecular meshwork. This is a smoothing picture of the gonioscopy showing sympathy line. So our differential diagnoses are pigment dispersion syndrome, pseudo-exfoliation syndrome, primary open-angle glaucoma, inflammatory glaucoma, and steroid-induced glaucoma. We ordered few investigations which included visual field testing, central corneal thickness, anterior segmentosity, and OCT-RNFL. Central corneal thickness was 525 and 590 micron meters in right and left eye respectively. This is a picture of the OCT RNFL showing thinning of the retinal nerve fiber layer in three quadrants. This is a picture of the anterior segment OCT showing posterior bowing of the iris, and there is a characteristic double hump sign. Similar picture was noted in the left eye of the patient. This is the visual field test of the right eye showing a central 10 degree of intact visual sensitivity surrounded by an area of loss of visual sensitivity. Similar picture was seen in the left eye of the patient. So based upon history and examination, our probable diagnosis is pigment dispersion syndrome. So our management plan is we infuse 20% IV mannitol at the dose of 2 ml per kg, followed by systemic and topical anti-glaucoma drugs. Patient was called to follow up after 5 days, and on 5th day, the IOP was 32 mm of mercury and 34 mm of mercury in right and left eye. Bilateral augmented trabeculectomy was planned. This is a pre-op picture of the right eye. This picture shows the post-op picture of the right eye in which peripheral iridectomy is seen at 10 o'clock and a well-formed blood is seen. Combined phacoemulsification and trabeculectomy was planned in the left eye. This is a video of the procedure. A conjunctival pedictomy is created, followed by conjunctival dissection to expose bare sclera. Mitomycin soaked swab is placed, followed by protease irrigation. A partial thickness scleral flap was created with the help of crescent knife. Phacoemulsification vein incident is also created at the same site. Phacoemulsification is performed here. IOL is inserted within the bag. Here, sclerostomy is created with the help of 11 number plate and scissors. Peripheral iridectomy is performed through the sclerostomy. Scleral flap is in suture bag with interrupting sutures, 10-0 nylon sutures. Following the closure of the scleral flap, conjunctiva is sutured back at the limbus. Great care is taken to ensure watertight closure of the conjunctiva to prevent later blood leakage. Scleral massage is done here to create the neck, and hydration of the site was created. So this is a picture of first post-op day of right eye in which a posterior flap is getting formed and radical iridectomy is seen at 10 o'clock. This is a picture after 1 week in which we can see the conjunctival atresia is settled and a well-formed posterior flap is seen. Intraocular pressure after 1 month was 8 mm of mercury in right and 10 mm of mercury in the left eye. So pupil dispersion syndrome is prevalent in third different decade of life in high myopes and it is prevalent in white face. There is actually posterior bone of the iris which causes iridozonular contact and release of pigment from the posterior iris. The clinical features are pupillary spindle, Xanthia lines, and Saponicine. It causes secondary open-ended glaucoma, and the treatment options are argon laser trabeculoplasty and trabeculectomy. A meta-analysis was carried out in 2021 comparing the efficacy of phacotrabeculectomy versus trabeculectomy with or without laser phacoemulsification, and the results show similar post-op IOP control with lesser complications and better visual acuity with phacotrabeculectomy compared to trabeculectomy alone. So our take-home message is beware of the pigment, perform early surgical intervention when required, and combine phacotrab is superior to trabeculectomy alone when coexisting ventricular changes are present.
Thank you, Dr. Mariam. For the fourth presentation, I would like to call Dr. Mumina Malik to present with you.
Assalamualaikum. I am Dr. Mughal Eye and I am first year resident at Mughal Eye Hospital. The title of my presentation is No Scars, No Tears. So a 41-year-old married female presented to us in the outpatient department on the 16th of December 2022 with a complaint of watering from the left eye with on and off discharge for the past 3 years. The patient was in her usual state of health around 3 years back when she developed epiphora in the left eye, which was accompanied by episodes of mucopurulent discharge. Her condition progressively worsened over time and was temporarily relieved by medication. There was associated pain at the medial temporal area. However, there was no history of nasal blockage or watering from the nose. The patient has used multiple topical medications for the left eye discharge and epiphora. There was history of probing and syringing done at another hospital, the record of which was not available. She is using glasses for near vision only. There was no history of prior surgery, laser treatment, injections, or continuous use of medication within the eye. The rest of her systemic history was unremarkable. On examination, the visual acuity of the right eye was 6 by 6, while that of the left eye was 6 by 9. The anterior and posterior segments were within the normal limit. While examining the lateral drainage system of the left eye, the patient had grade 4 epiphora with history of dabbing more than 10 times a day. Regurgitation was positive in the left eye, and the dye disappearance test was delayed and showed presence of dye even after 5 minutes. There was slight swelling inferior to the medial canthus. However, no lacrimal sac mucocele or signs of acute dacrocystitis were noted. The examination of the lacrimal drainage system of the right eye was within the normal limits. So, based on the history, then we performed the probing and the syringing of the patient. During probing, a hard stop was felt, which indicated patent finalicula pathway, and syringing showed reflux from the superior tonsil. No taste of saline was felt within the throat. So based on the history and the examination, we reached to a diagnosis of chronic dacrocystitis. As this was a female patient and she had great concern regarding the prosthesis, so we planned an endoscopic dacrocystorhinoscopy under general anesthesia. Pre-op nasal evaluation was done by ENT specialists to rule out any nasal pathology. Decongestant nasal spray was started pre-operatively and the pre-operative labs of the patient were within the normal limits. So these are the per-op pictures. The position of the patient was supine with a head pack was placed which consisted of a decongestant adrenaline and transdermal. Zero-degree endoscope was used for this procedure. So we'll have a quick review of the anatomy of the lateral wall of the nose. This is the nasal septum and this is the lateral nasal wall. The base of the attachment of the middle turbinate holds great importance as anterior and superior to this, the lacrimal sac is present. So the incision for this surgery is given 8 to 10 millimeters superior and anterior to the attachment of the base of the middle turbinate, and it extends downwards towards the inferior. This is the per-op video of the surgery which was done by Dr. Khaja Khalid. As you can see that the incision has been given here. Now the nasal mucosa is being elevated using a rear periosteal elevator. After elevation of the nasal mucosa, the lacrimal bone has been exposed, which is being dissected with the help of a Garrison bone punch. Now, it is very important to maintain hemostasis during this procedure because even a mild bleed, it can obscure the view and result in decreased success rate of complications. So, after dissecting the lacrimal bone, here the lacrimal sac has been exposed. And as you can see, after giving incision to the lacrimal sac, there is expression of mucopurulent discharge from the sac. Now the incision is being widened to create an H-shaped flap, and the DCR tube is then placed. This is the 1-month post-op picture of the patient in which the DCR tube can be seen clearly. The post-op evaluation on the first post-op day, the patient still had grade 4 epicora. There was mild nasal bleed and mild ecchymosis of the eyelids, but the dye disappearance test was positive after 5 minutes. On the third post-op day, the epicora had improved to grade 2, the nasal bleed and the ecchymosis had subsided, and the dye disappearance test was positive after 4 minutes. On first week post-op, the epicora was of grade 1 and the dye disappearance test was positive after 3 minutes. And on 1 month post-op, the patient had grade 0 epicora. The syringing result was successful and the dye disappearance test was positive after 2 minutes. So whenever a patient with epicora is going to come to us, we always have to grade that epicora, and that is done using the Munk scale. So according to the Munk scale, grade 0 means no epicora, grade 1 is epicora requiring dabbing less than twice a day, grade 2 requires dabbing 2 to 4 times a day, grade 3 requires dabbing 5 to 10 times a day, and grade 4, as in this patient, requires dabbing more than 10 times a day, and grade 5 is liver when there is constant epicora. We'll have a quick comparison of the external DCR compared with the endoscopic DCR. So this is the post-op picture of a patient who underwent external DCR. You can see the scar mark and there is a marked swelling of the periorbital region. And this is the post-op picture of a patient who underwent endoscopic DCR. So there is great improvement regarding the cosmesis of the patient with the endoscopic approach. Endoscopic DCR, it requires no external scar mark, there are less chances of hemorrhages, less chances of CSF rhinorrhea, and there is no destruction of the lacrimal pump function. The success rate for external DCR is greater than 90%, and it is 60 to 100% for endoscopic DCR depending on the expertise of the surgeon as well. So recent studies have been conducted which are comparing the results of both the procedures. This study was conducted in Taiwan over a period of 8 years, studying 178 cases. And according to this study, the success rates of both the procedures were comparable. But if we look at the time to symptom relief, it was significantly less, 1.7 weeks for endoscopic DCR as compared to 3.7 weeks for external DCR. Similarly, another study has been conducted in 2021 studying 100 cases, and the conclusion was that endoscopic DCR yields comparable results to external DCR, but it offers additional benefits of aesthetically better outcome, lesser complication rate, and short surgery and patient recovery time. So the take-home message for us is that although endoscopic DCR is a slightly expensive procedure with a steeper learning curve, but it is more beneficial for the patient regarding cosmesis and better patient satisfaction rate than the external DCR. Thank you.
Abdul Rahman to present your case.
Bismillahirrahmanirrahim. Assalamualaikum. My name is Dr. Neha Abdul Rahman. I am a senior PGR at Mughal Eye Hospital, and the title of my presentation is From Science to Creation. 43-year-old male patient, resident of Lahore, restaurant manager by profession, married, presented to us with complaints of left side pain that was radiating to the temples, redness, and watching all since last 4 months. The examination of the left eye showed visual acuity 618, whereas best corrected was 66%. The conjunctival vessels were congested, the episcleral vessels were dilated, and there was a slight gray blue appearance in the upper quadrant of the sclera. The right eye examination revealed visual acuity 69, and so was best corrected. The pupil was irregular, mid-dilated, and sufficiently reactive to light. The lens had posterior subscapular cataract. We made a provisional diagnosis of non-necrotizing diffuse anterior scleritis in the left eye and pupil uveitis in the right eye. But there's a little twist to this presenting complaint. The patient was in a normal state of health when on 16th May 2021, he received a dose of AstraZeneca. The very next day, on 17th May 2021, the patient developed pain around knee joints and knockings around small joints of the fingers. He visited an orthopedic consultant and treatment was given for that, after which the inflammation subsided. On 1st June 2021, the patient developed decreased visual acuity of the right eye and there was redness. He visited some other hospitals and was given treatment for acute anterior uveitis. His inflammation subsided, however, some posterior findings were found. We can see the posterior signings in this picture. On 7 September 2021, the patient developed oliguria, periorbital, and pedal edema. For which he visited a nephrologist. The nephrologist admitted him to the hospital and he was given treatment for acute kidney injury. But since it was a multi-system involvement and autoimmune profile was ordered. And C-ANCA came out to be positive. The patient was started on high-dose oral steroids and oral mycophenolate, and injection cyclophosphamide 1 gram SAT was given, and few more were given later. This is the report of patient C-ANCA, and you can see the levels are raised. They are greater than 200 AU per milliliter. The patient remained admitted in the hospital, and C-ANCA levels started to come down. The condition got stable, and the patient was discharged on maintenance care. This is another report of patient C-ANCA, which shows the levels have gone down to 50 AU per milliliter. The maintenance therapy that was given to the patient was mycophenolate mofetil 1 gram per day per oral, and the C-ANCA levels came down to negative, and the drug was stopped. This is a patient's report which shows the ANCA levels are now negative. They are 8 AU per milliliter. Now, on 22nd September 2021, while the patient was receiving treatment for nephritis, he developed numbness on one side of the body and monophyresis. He consulted a neurologist, received treatment for stroke, and paresis got better. This is now where we stand. The patient has scleritis, he is taking topical steroids and NSAIDs and oral painkillers, but it is not evolving since last 4 months. This is the current picture of patient's left eye. When the patient presented to us, he was systemically stable. We made a differential diagnosis of drug-induced ANCA vasculitis and granulomatosis with polyangiitis, which is the new name for pregnant granulomatosis. We have put pregnant on second number because it is a sign of nephritis, sinusitis, and lower respiratory tract infection. But this patient had other system involvements as well, so we put it However, because of the history of COVID vaccine, we will put blood induced on number one. The investigations that we performed were CBC, ESR, C-reactive protein, and C-ANCA. In this, we can see the ESR is raised and the CBC shows anemia. His RFTs, the renal function tests, are all deranged. And C-ANCA has some positive again. The levels are 51.9. Probable diagnosis is relapse of C-ANCA vasculitis. So the patients who are taking C-ANCA, so the patients who have C-ANCA, they have to take chemo for a very long period of time. We have referred the patient to an internist, and his immunosuppressive therapy has been started. Meanwhile, we are symptomatically treating his therapy. The survival rate for vasculitis patients is for 2 years is less than 20% without immunosuppressants. However, when we give the patient immunosuppressants, the survival rate for 5 years increases to 90%. So the vasculitis can be large vessel, medium vessel, and small vessel. Our patient's criteria is ANCA positive small vessel vasculitis. ANCA vasculitis is a group of rare autoimmune conditions which causes inflammation of the blood vessels and it has various manifestations. C-ANCA, however, is positive in 90% of cases with granulomatosis with polyangiitis, and many medication exposures are linked to the development of vasculitis. This is a picture showing how multiple systems are involved in vasculitis. A single center cohort study compared rituximab versus cyclophosphamide for refractory cases of systemic involvement in vasculitis, and we can see that rituximab treated 91.7% cases, however, cyclophosphamide treated 72.3% cases. Another study saw the clinical effectiveness of rituximab in the treatment of refractory scleritis in patients with granulomatosis with polyangiitis, and the rituximab was successfully used as treatment. So the take-home message is: eyes are the windows to the soul. Always look for signs of systemic disease in a patient with scleritis. These are the references. Thank you.
It was a very good presentation. Did you search on the internet? Is there any other case report visit?
There is one case reported procedure. One case procedure. There is a case reported procedure of the same case, and we also received AstraZeneca and he developed the same spectrum of Thank you, everyone. Now I would like to request our national guest speaker, who is an assistant professor of endocrinology and cardiotechnologist, Dr. Amina Mausam Pekwaza. Madam, thank you very much for joining us. Please.
that's most merciful to mankind. I am Dr. Arman Mosque. To start with, I would like to thank the administration and the board of directors for inviting me. I am an assistant professor of endocrinology in Department of Endocrinology and Metabolism at Service Institute of Medical Sciences. I am also the supervisor and examiner for FCPS and MRCs being conducted locally. To start with, I would like to comment. I could not stop but comment on the presentation of the PPs. It was excellent. The presentation skill, the slides, everything was excellent. So I will be taking up the topic of screening and surveillance of diabetic eye disease in the scenario of low To start with, I would request you all just to give me 2 seconds, just to get the slide and just tell me what comes into your mind. Just 2 seconds. Just have a look. Can you identify yourself? What do you see?
I see you should tackle the problem, not the incident that is happening with the problem.
Excellent. I think I asked the wrong person. You. Scanner paper release कर दिया. Parents after school.
The cause is not being treated. They are just
Excellent. Just hold on to the thought and we'll take it forward. So the topic was screening, surveillance, and low-income countries. These are the 3 major points that we take forward. I'm basically a clinician, but when I was approached for this lecture, for this talk, I didn't know what topic should I choose. So I chose a topic which will be of use to both of us as a profession. So what do you see in this, madam? Iceberg. So what is the iceberg model?
there's more to it than we can see.
Excellent. So my topic, which is screening. What does screening do in an iceberg model? Yes. Anyone? What screening does is that it identifies the typical cases which are the diagnosed cases that appear to our clinics. And the submerged part is those apparently normal people, which we don't see till it's too late. So screening is the method to differentiate between the apparently normal people from the diagnosed. Surveillance, on the other hand, is an ongoing process in which we collect the data, analyze it, and it is used for a higher purpose to bring a change in the system. So why? Why did I choose diabetes eye? Why? Because it is preventable. So prevention is the topic to discuss. And that is why I am here. What do you see? This is a very busy diabetes OPD, which we see at Services Institute of Medical Sciences. The number is rising rapidly, 5.37 million people worldwide. 6.7 million people die because of it, and 4 out of 5 live in low-income countries like us. What does the atlas show? 2019 में हम 4th level पे थे. Suspected ये था कि 2045 पे हम ऊपर आएंगे, 3rd and 2nd पे. मगर we were unlucky. हमें 21 में जाना. मगर ऊपर. Not done. So the number of diabetic patients is increasing, and for you, the complications, the diabetic eye is reducing. I discussed the word low income country. Why are we discussing this? अगर आप ये देखें, यहाँ हमने states के साथ compare किया है. इस साइड पे GDP है, ये years हैं. Their GDP per annum is increasing on it, whereas ours is decreasing. What is this? This is out of the pocket expenditure. अगर आप हमारा देखें, तो ये yellow part जो है, yellow oil है, which is more than 80%. Is out of the patient's pocket expenditure of their illness, whereas a vasoconstriction 20%. Thus stressing upon the importance of prevention एक बीमारी जो प्रिवेंट हो सकती है, why let it happen? And since South Asia comprises 1/4 of the global population, it is still very unrepresented. इसकी ऊपर papers, इसकी ऊपर research बहुत limited. जो मेरा आज का मकसद है is awareness. Awareness क्या है? Data collect करें. So data collect होगा, know of the problem that you have. Once you identify the problem, you can treat the problem and prevent the complications. Once complications होगी, there's nothing more we can do except rehab. आपको मेरी समझ पता है. So it is a public health problem. It will affect each one of us. ये मेरे पड़ोसी में नहीं होगा, ये दूसरे प्रोविंस में नहीं होगा, ये हमारे भी घर आ सकता है मसला. So we need to sit and talk and identify and work in cooperation. अकेला बंदा काम नहीं कर सकता. Diabetic retinopathy, as you know, it's the disease of retina because of diabetes. It is the fourth leading cause of blindness and the fifth leading cause of visual impairment. Why is it important? Because it affects the quality of life. आपके आपके घर वाले. Estimated 1/3 of these diabetics will suffer from DR. 1 in every 10 will have vision threatening DR. And 27% of the world is affected. Coming to diabetes, it is seen that type 1 diabetics, 90% of them will develop diabetic retinopathy of some form, whereas 60% will develop it in type 2. What is the burden in Pakistan? Yes, medical research is very limited because we hardly examine. Good centers like you do, but the therapy which matters, they don't. एक स्टडी हुई थी आपके यहाँ मेटा एनालिसिस, इसके अंदर उन्होंने हमें ये बताया कि as you can see, with increasing age, the incidence is increasing and more so in the females. So what are the risk factors? The longer the duration of uncontrolled diabetes that you have, uncontrolled hypertension that you have, are the risk factors that you will develop some kind of retinopathy. As you can see, type 1 के अंदर ज़्यादा incidence increase हो जाता है visual threatening का 8.79% बताता है. So what can we do? We can have a uniform strategy to manage these risk factors to avoid. How do you? What are the strategies? जैसे कोई भी disease की strategy होती है, primary, secondary और tertiary level. Primary level क्या होता है? कि you avoid the disease from happening. Diabetics को उनका lifestyle उनकी medicine कितना करें कि उनके अंदर complication आएगी. Secondary में क्या होती है? कि once identified, आप उसके risk factors को करें उसको screen करें. Tertiary is only rehabilitation. The damage is done. So this is what एक मैंने ड्रॉ किया ताकि आपको समझ आ जाए. Primary में you avoid diabetic patients की आप awareness improve करते हैं, with the awareness करते हैं to avoid retinopathy. Secondary to the early diagnosis and treatment. Tertiary is only rehab. Unfortunately, what we are doing is only the tertiary care. आप भी जैसे हमारी तरह tertiary care unit है. Patients come to you at the last stage. उन्हें क्या चाहिए? tertiary के बजाय primary और secondary levels पे काम करना है. This is what I am stressing upon. What are the challenges? What do you think are the challenges, sir? आपका क्या है? आपके पास तो काफी patients आते हैं. What challenges do you face? Excellent. Sir, ये ignorance सिर्फ patient तक नहीं है, जो parents भी हैं, doctors हैं, उनकी भी है. So number one is lack of awareness at the level of patient and the physician. They are not willing to listen to doctors. Now, आप ही सुनते होंगे ना हमारी lifestyle modification. There are lack of guidelines. National, international guidelines अगर हैं भी तो हम disseminate नहीं करते. Periphery में बैठे लोगों को नहीं पता. आपको मुझे पता है. That's all. Lack of screening tools. There are no cameras. Fundoscopy नहीं होता उनके पास. And inadequate liaison. गांव से पेशेंट लाहौर तो आ गया, मगर आप उसको ये नहीं पता समझाना है. So what is the approach? Number one, to develop guidelines, local guidelines. International अगर है, if they are good, it's all right. वरना nationally adopted guidelines.
पब्लिक हेल्थ अवेयरनेस जैसे सर ने कहा उसको डिजिटलाइज करने की जो जमाना डिजिटलाइजेशन का स्क्रीनिंग अपने स्क्रीनिंग टूल्स और टेक्नोलॉजी को एडवाइस करें एंड फाइनली इंटीग्रेटेड अकेला बंदा कुछ नहीं कर सकता we all have to join hands to prevent this disease as it is preventable in the early stages ये गाइडलाइंस 88 की है which we follow I'm sure आपकी भी अपनी होगी एक ही ट्रिब्यूनल है आपको पता है टाइप 1 का after 5 years of diagnosis करते हैं टाइप 2 at the time of diagnosis करते हैं और pregnancy में it is extremely important that female diabetic patients who are planning to become mothers या who are pregnant should be screened for it ये images मैंने आपको सिर्फ दिखाया how you digitalize, how you improve the screening and surveillance. ये नाइस की गाइडलाइंस है जिसके अंदर उन्होंने अगर आप देखें उन्होंने इस प्रिंट छोटा है लेकिन जस्ट इन्फॉर्मिंग यू पेशेंट आया अपने स्क्रीन कर दिया इसको करना है प्रेगनेंट के नहीं है प्रेग्नेंट है कि नहीं है प्रेग्नेंट है उसका अपना हेल्प हो जाएगा प्रेग्नेंट नहीं है सेपरेट जाएगा फिर इसको आपने एनुअली बनाना है 6 मंथली 3 मंथली प्रोसीजर्स क्या करने हैं ये if you digitalize it, if you have permanent records पेशेंट का फॉलो अप आसान करता है आपके लिए भी और पेशेंट के लिए पेशेंट को पता होता है इसमें हर 3 माह बाद आते हैं उसको आप कॉल भेज सकते हैं उसको आप एसएमएस कर सकते हैं दिस विल इंप्रूव द सर्वेलेंस इट विल इंप्रूव द प्रिवेंशन ऑफ डिजीज डायबिटीज इन प्रेग्नेंट लेडीज ये भी उसका पूरा एल्गो बना हुआ है आई एम श्योर सर आपका भी ईएमआर सिस्टम होगा इधर डेटा कलेक्शन का आप ये सारा डॉक्टर कर सकते हैं इसको whom to screen we all know all diabetics pregnant ladies and especially those with other complication diabetic foot से आया renal failure से patient आया उसकी आंख आपने जरूर देखनी है they are one and the same thing if one is affected the other will be affected so these are the high risk patients that we need to screen yes sir just 2-3 slides just to show you what we are doing at services because sir I'm working at diabetic center we are a tertiary care center we cater to more than 200 to 300 diabetic patients on daily basis our aim is to yes control the blood sugars and avoid complications yes this is our aim how successful we are I don't think we are 100% successful why because still it is not an integrated system What we do कि पेशेंट आता है उसकी एनुअली रेटिनल स्कैनिंग हम करते हैं और जो एट रिस्क होते हैं उनको हम रिफर करते हैं कोई जाता है कोई नहीं जाता What we've done here with some sponsorship हमने एक वेलफेयर काम शुरू किया है जिसके अंदर we screen the eye with the retinal scan and it is a community-based international multi-center screening program called the Global Health Research GHRE in cooperation with Primary Secondary Healthcare Department of our government and Imperial College London. सर ये हमारी मोबाइल हेल्थ यूनिट है ये पंजाब की डिफरेंट सिटीज में जाता है मैं आपको दिखाती हूँ और हम उधर क्या प्रोवाइड करते हैं सर दीज आर द फैसिलिटीज वी प्रोवाइड हैं हम उनका बीपी वेट भी करते हैं एक्टिविटी स्कोर स्पाइरोमीट्री भी करते हैं पॉइंट ऑफ केयर टेस्ट जिसमें HbA1c कोलेस्ट्रॉल करते हैं retinal scan करते हैं ECG करते हैं and we all digitalize it we save it in the computer server के अंदर हम करते हैं और फिर उस डाटा को हम एनालाइज करते हैं थोड़ा फ्यूचर पर्सपेक्टिव के हमने क्या करना ये मैं आपसे रिक्वेस्ट करना चाहता हूँ सर आपका बहुत माशाल्लाह you doing a lot but I think you can do further more by involving the community so ये हमारी on work सारी पिक्चर्स हैं These are the areas. हमने पंजाब को भी फोकस किया है सर. This is only Punjab. These are the areas that we have worked on. So my last slide, sir. What are the recommendations? Increase awareness amongst patients and physicians. CMEs, short programs रखें जिसमें आप awareness कर सकें. Doctors को आप बहुत अच्छे consultants बहुत अच्छे बना रहे हैं. मगर सर हमारी backbone है general physicians. जब तक पेशेंट रिफर नहीं होगा कंसल्टेंट क्या करेगा नंबर 2 गाइडलाइंस को डिसेमिनेट करें प्रिंट आउट्स बना दें फ्लायर्स बना दें लीव देम एट द डेस्क उनकी टेबल्स पे पड़े दे नो व्हाट टू डू स्क्रीनिंग टूल्स चले कैमरास नहीं है फंडस तो हो सकती है ठीक है एंड इंटीग्रेट प्लीज उसको अपने साथ करें बेसिक हेल्थ को रूरल के साथ रूरल को डिस्ट्रिक्ट के साथ सब कंबाइन होना चाहिए ये नहीं हो सकता कि फिर जब ब्लाइंड हो गया तो टर्शरी में तब तक इट्स टू लेट So, sir, this is the slide. Physician is the key to success. The general physician. He's the key between the patient, the health department, the NGOs. NGOs, माशाल्लाह बहुत काम करती हैं, मगर जब तक हम integrated नहीं हैं, कोई फायदा नहीं. As a nation हमारा मसला ही है. So, madam, आपने sir ने भी कहा था. Coming back to the reason, if we don't treat the cause, end result को करने का क्या करें? Thank you, sir. Thank you.
अच्छा डॉक्टर आपने एक दो चीजें मैं आपसे डिस्कस कर रहा हूँ what do you think the issue is about the treatment or resources or availability of endocrinologists or issue something else what do you think the most important issue in dealing with diabetes disease in general in whatever that's I wanted to hear the only thing you can get million endocrinologists, you can get thousands hospitals, but until unless you will not give the awareness how to prevent this disease, how to change the lifestyle, nothing is going to achieve. आप अपनी मोबाइल वैन को चाहे गिलगिस्तान ले जाओ जहाँ मर्जी ले जाओ वो क्या करेगी जब तक लोगों में इसकी प्रिवेंशन की नहीं होगी. Second thing, you see your patients. How many times when you follow your patient of diabetes, you recommend your patient to visit to ophthalmologist or retina physician for fundoscopy. And when he or she does come to you second time, do you see the notes of ophthalmologist whether he or she has visited the ophthalmologist or not?
सर आपकी पॉइंट बहुत वैलिड है जो हम सर्विसेज में सिम्स में करते हैं
नहीं सिम्स को छोड़ दें आप प्राइवेट क्लिनिक
सर आपकी बात ठीक है हम एडवाइस जरूर करते हैं थ्री थिंग्स वी एडवाइस follow up के ऊपर we tell them we ask them they say yes or no we do not pressurize yes or no
so I share my if a patient of diabetic retinopathy comes to me I will examine him I will advise him all the necessary investigation and I refer to the endocrinologist and he or she should visit me if he or she is visiting me until unless they have not visited their endocrinologist I don't follow that patient. Would you like to continue in your practice?
Excellent.
If you will do like this,
yes.
Your patient will do the ophthalmology examination. If you will say next time if you are coming and if you don't have a notes of ophthalmologist, don't come to me or if you are coming, I will not give you the treatment.
Excellent. Excellent one.
Otherwise, there is no option. If you cannot push, you have to push. With this society, do you think that they will understand what's the necessity? No, you have to push. It is our job to push.
Yes.
That's all. And second is awareness. We should all take the responsibility. Every ophthalmologist who is dealing with the diabetic retinopathy, he should follow this patient the next time unless he or she has not visited an endocrinologist in the recent 1 week or 7 days. And same should be applied to the endocrinologist.
Excellent point.
Excellent. It's not just an endocrinologist. The patient has to go to a nephrologist.
Excellent.
It's got a diabetic retinopathy.
Be physician, at least be physician.
Madam, वो necessary है at least a physician. It should be. Unfortunately,
I think it should be targeted.
It should
Not
be.
prevention.
अच्छा, it should be targeted. और ये तो सही है कि उस गांव में हमारे मैसेज रहती हैं, उधर हमारा जनरल फिजिशियन से भी इन्फॉर्म करना होगा.
That's another aspect.
That is the actual aspect of it. This is the
Once the patient has reached to your clinic, once the patient has reached to a tertiary care center,
yes.
then the reference has to be done.
Thank you. Very well.
Thank you very much, madam. For our final talk, we have an international guest speaker, Dr. Muhammad Tawfiq, who is a consultant retinal surgeon working at Memorial Institute for Ophthalmic Research at Egypt.
Good morning, everyone. My name is Dr. Mohammed Tawfiq. I'm a vet retinal consultant from Egypt. It was a great pleasure and honor from Dr. Hussein, Professor Dr. Hussein Khan, for this invitation. I will speak about the surgical management of submacular hemorrhage. First of all, what is a submacular hemorrhage? A submacular hemorrhage is a term which describe a condition characterized by the presence of blood in a potential space between the retinal pigment epithelium and the retinal layer. I mean that the space between the neurosensory retina and retinal pigment epithelium, it's a space that we call the subretinal or submacular hemorrhage. Most common cause of subretinal hemorrhage is the choroidal neovascular membrane. It's the most common cause, usually associated with high myopia, age-related macular degeneration, trauma, angiopathic streaks. It may be idiopathic, and also even during surgical procedures, draining of submacular fluid and scleral buckle may lead to submacular hemorrhage and adverse scleral perforation during strabismus surgery, or association with a localization of melanoma margin during radioactive plaque, also laser photocoagulation. And penetrating trauma, hemorrhagic retinal detachment, combined suprachoroidal hemorrhage and retinal hemorrhage. And also some may occur in ruptured retinal artery microaneurysm and something like this. So, injection of submacular TPA for submacular hemorrhage. This is a reported lectures about the effect of intravitreal injection or for the TPA injection, or for injections of the TPA in submacular area. And this slide is very important. You need to screenshot of this slide because it's explain to you what is the dose of TPA and what is the brand name of TPA in your market and how to dilute the TPA. The TPA in our country is the marketing name of TPA is called actylase. It's a 50 milligram. 2 vials, 1 powder and 1 sterile water. We need to use 1 vial and one sterile water and 1 powder. Its concentration at 50 milligram, I mean, is 50,000 microgram in 50 ml. So the submacular dose is 20.5 microgram per 0.1 ml. So how to dilute it? 1 ml is diluted on 7 ml water. So 1 ml now is 125 microgram, then take 0.1 ml, so this is the dose for you, it's a 12.5 microgram per 0.1 ml. The toxic dose is 50, so you can inject up to 0.3. This is an important point. Before you go for the surgery for submacular hemorrhage and to inject the TPA, you need to prepare yourself with this cannula. It's called 41 gauge cannula. It's from outside 30 gauge or from inside 41. So you can buy it in the market by call the company, please, I need to ask 38 gauge cannula for submacular injection or 41 gauge cannula. It's the same because it's in an outer diameter 38 and an inner diameter 41. This is a small video to showing you how to prepare. The sterile water is diluted in the powder and use this syringe. This syringe is from mid-1 cannula is titrated 0.1, 0.2. You can put on this syringe at maximum amount of 0.3, maximum volume of 0.3. If you have a Constellation machine, this syringe can be connected with a silicone injection kit, so you can control the injections actively, not passive. So by foot switch, you can inject and you can control and titrate the amount of injection force. So you need to put it in a gripping force, not in jet force. This is a jet force, decrease the amount of injection to take it to make it drip. As you can see, just maximum 0.2, 0.3, go for the trocar and choose where is the site of injection. In such a case, for a moderate size of submacular hemorrhage, I usually inject in the down, in the inferior macular area, in the inferior arcade, increase the volume of the injection until the macula is detached. And may use another point of injection and then put a small bubble of air with a partial fluid air exchange. The partial fluid air exchange, not a full fluid air exchange. And to make the patient post-operative take a semi-setting position, because when he takes the semi-setting position, the air is coming up and pushing the submacular fluid to go to down with an area that I'm detached with the TBA. And this is a post-operative of this patient. Again, this is a patient with severe hemorrhagic age-related macular degeneration. And as you can see in the video, in such a huge hemorrhagic AMD, I used a multiple site of injection. First down, and then temporal, and then upper, and all of them is just a TBA. Maximum dose of 0.3. It's just it. You can see this is the third pinch. And when I feel that the macular area is totally detached and there is a potential space down, I inject in the air in the down area, the potential space, and asking the patient to go for a semi-sitting position with a partial fluid air exchange. Remember, it's a partial fluid air exchange, and the patient need to take a semi-sitting position. If you make it full fluid air exchange, there is no space for the fluid or the blood underneath the macula to go down. And this is the post-operative of the patient. You can see how it's amazing the TBE work for disclosure or liquefaction of the blood, and the retinal pigment epithelium is absorbing this blood. This is an unusual case of submacular hemorrhage. First impression for me, it's an Asian female, 70 years old, and I suspected hemorrhagic AMD. And I go through for the surgery for injection of submacular TBA in such a hemorrhage. You see the OCT of the right eye and the left eye. As usual, I do the vitrectomy and injecting the submacular TBA. But in this case, I first do a detachment of the retina and then injecting the TBA. So as you can see here, I'm not now injecting the TBA. I'm injecting saline to make a detachment of the lower retina. And after that, I injecting the TBA. So I changing the syringe twice. First one, it was just a saline. Second one, it was a TBA. Third one, it was an air bubble. Because I feel that I need a large potential space down there to make the fluid is coming, to make the space for the fluid and the blood to go down. But be careful in what's happening. The lower retina is totally detached, and I think it's totally detached. As you can see, post-operative, the fluid is going down, the blood maybe is starting to clear. This is an air bubble out there. This is the second day post-operative imaging. And I think the fluid may be starting to go and down. But after just 1 week, the blood regain again. And we have again submacular hemorrhage. And I started to thinking, is it a recollecting of blood behind the macula or it's a rebleeding? So I do the OCT and asking the patient to do the fluorescein angiography, and we confirm that this is a macroaneurysm rupture, not an hemorrhagic AMD. And we can see the blood is covering the whole retina. And I was doubt, is it an recollecting of the blood who is going down or it's a rebleeding? But I decided it's a rebleeding. So I decided to go with another injection of TBA and also injecting of anti-VEGF. In this case, I used the Lucentis anti-VEGF over then the TBA, and also the same, just injecting the TBA here. I didn't inject the fluid, I didn't detach the retina, just one injection upper temporal, and one injection lower nasal, and I injecting the Lucentis in such a after finishing this case. And as you can see, post-operative 1 day, the blood is starting to clear. 1 month, the blood starting also to clear. The OCT of the patient become dry. So I keep following the patient and didn't interfere anymore. By following up the patient is gaining like 160 visual acuity, and the macula is starting to being dry, and the color fundus of the patient is, as you can see, it's starting to clear, and the vision of the patient is going to be improving. So my take-home message in such situations of injection of TBA to treating the submacular hemorrhage. Injection of TBA to treat the submacular hemorrhage, you need to know 3 things. First, prepare the drug. if you don't have the knowledge to prepare the drug, you need to know to have the knowledge to prepare the drug. Second, you need to have the cannula, 41 gauge cannula, because we don't have this cannula, you cannot able to do the surgery. Third, it's an optional. You have a syringe titrated 0.1, 0.2, 0.3. It's help you to control the amount of the injection that you will inject behind the retina. And this syringe is from Medone. If you don't have this syringe, you can use a routine insulin syringe and you can inject it either by passive injection by using your hand or by connecting the syringe of Medone to the constellation machine of your machine to the silicone injection kit. What is the difference between manual injection and the active injection, active injection through the machine? Because the active injection through the machine, you can inject by your pressing the foot switch, and you can control the force of injection. In your hand, you are not able to control the force of injection. And also, you don't need to inject the saline behind the retina. You just need to inject the TPA maximum dose of 0.3, maximum amount of 0.3. You don't need to inject the saline, and you didn't need to detach the retina. Make the tamponade is partial fluid air exchange with the patient semi-setting position to help the blood to settle down. And also, if you face a scenario like the last case, if you have a recollecting of blood or free bleeding of blood, you may take the chance of the patient to have some times of follow-up. Maybe the blood is recollecting, not free bleeding. And I hope I can adding something to you. And thank you again. And thank you, Dr. Hussein, for your invitation. And hope it will be here.
And many of us know this tradition also. We have also written a book, book about memories about him, about the people who interacted. So if anybody is interested to read it, so this is a small book that we have made it, and there are a few points that people has highlighted about his life, and those who don't know him or the younger one, they will know who he was and how he served the nation. Professor Timothy Patsavi said he was his last fellow, and they spent the ophthalmology career and MBS career together till the last day. And I still remember how we were rushing on the 18th February 2013 to see him how and his condition is. So it's just reminding he is good and he did very well for the ophthalmology of Pakistan and for the ophthalmology of Pakistan. May Allah bless him and high place in Jannah. So now we come to the clinical part of this OSP clinical meeting. So as the madam has to leave early, so we will request madam to join us and to get the certificate. I will request Professor Dean, who is part of our dice, and present the certificate to our guest speaker. Okay. And now I will request Professor Dean to please present the. Thank you. Thank you. Thank you for that. Very good talk. Thank you. So, now we come to the results of our scientific session, and we have the results. Results are just for the numbers, so everyone is winner today, everyone presented very well. So the main step is that the winner is going to a grand round and grand clinical meeting that the big work, and he is getting a partner souvenir pens from us and certificate. So the winner of today's presentation is Dr. Momina Malik. Dr. Momina Malik. I will request Dr. Shehbaz, please come and present the seminar. Dr. Momina, please come. And second position goes to Dr. Neha Abdurrahman. I will request Dr. Shehbaz, please come and present. She has a very unique scientific, she should publish it and send to the publication journal for the case report. I think it will be sufficient and high respected journal. हमारी लाइट की वजह से मुझे कुछ नजर नहीं आ रहा। Third position goes to Dr. Mariam Nasrullah. Dr. Mariam Nasrullah. I request the college please.
इससे पहले कि बुक करिए
So it doesn't mean that others are not the winner. Everyone is winner today, and everyone is doing good. So I will request the next Dr. Ali Hashim Zubair. Please come and present. Now I will take very briefly to come and present the certificate. Come on the center. You go on the right side.
and you all come forward.
आगे मैं बोल जाता Actually, this is also the grooming how to get the certificate, how to present it. So this the young lord should learn from. Thank you. Thank you. The next one is Dr. Anum Khan. Anum Khan is very welcome. So this is the everyone to be here. That's it. More brother happy. Now I will request Mega Pharmaceutical representative to come and get the certificate. Mega Pharmaceutical representative. They are the sponsor of today's meeting. So come here, anyone. Now I request Colonel sir, please come and get the souvenir or the today's arrangement. So now I will request the head of department, Shiva sir, would you like to join in vote of thanks and then
Thank you, sir. Finally, I would like to invite Mr. Fazil Mughal sir, Board of Directors, to give the vote of thanks and conclude the meeting. Sir, please. First of all, I would like to thank you everyone for participating today on behalf of the trust and chairman of the board. That you all participated. I would like to thank the OSP for becoming a host and holding this event at Mughal Eye Hospital Trust. We hope that this continues in the future as well. And I would like to appreciate and congratulate all the participants who have participated in today's presentations and made their effort with their mentors. Especially thanks to Dr. Shahbaz Saab and Colonel Saab for making this event possible today, and OSP's management and president of the institute. So thank you everyone, and we hope you had a good time and it was a good session. Thank you. Thank you very much, sir.
Thank you very much for joining this OSP event, which is held every monthly in different institutions. Sorry, I was preparing for going to Malaysia today, so I got delayed in that. But I'm glad to see there's a lot of attendance, and thank you very much to the Mughal Hospital team, the administrators, and the CEO. Thank you very much for coming. Welcome, Professor Nadeem. Please, thank you very much for coming. And I'd like to share with all the OSP members that Professor Nadeem is sort of in the election campaign for Vice President of APAO this year. So we hopefully that we are confident that we finally be a representative from OSP Lahore, especially in that event. Otherwise, as the OSP members are going to be about meeting, a lot of people are getting awards. I think Khalid is giving a talk. Are you giving a talk for that? Either we see talk, Farman is getting an achievement award over there, I'm getting some award over there. Or always there is something. After the highest pedestal, you're going for vice president, he's getting an achievement. Or we see the award, right? Thank you very much. I hope the juniors will be whenever an international meeting is there, OSP always promotes that. Please do submit abstracts so we have a voice in the international arena for ophthalmology as well. Thank you very much.
now the lunch is ready. Please join us for the lunch. Thank you.